Hello to my colleagues across the Australian Public Service and welcome to the Connecting Us podcast. My name is Mif Nazette and I work at PM&C in the Connecting Us editorial team. I'd like to start by acknowledging the traditional custodians of this continent and pay my respects to elders past, present and emerging. In this edition of Connecting Us, we're talking all about the science work conducted across the APS and the amazing scientists who are working on projects that you might not expect. Check out the edition to read some of those stories. But right now we're going to be talking about some of the highest profile science going on at the moment, and that's health science. With me today I have one of Australia's Deputy Chief Medical Officers, Nick Coatsworth. Thanks for taking the time to have a chat with us today, Nick. I know you must be super busy at the moment.
It's a pleasure, Miff. I'm really happy to be able to talk to colleagues in the APS. I'm pleased to be a colleague in the APS. I wasn't before, but now I am. It's been a really interesting experience.
Okay, so what are your first impressions of being in the APS then?
Well, my first impressions were on March 23rd when I first walked into the National Incident Room, and of course the pandemic, the first wave, was nearing its peak. And what I saw just gave me extreme confidence with the sheer amount of human resource and smart, competent public servants working on this, not just in health. Of course, health had the coordinating role, but throughout departments, PM&C, DISA, DFAT. This was truly a whole of government response. So one of the first things that struck me was, if given my experience, I'm walking in here and I'm feeling confident, why is the rest of the country not feeling confident?
Okay.
And so I really felt that quite acutely on the 23rd of March and basically decided that it was going to be my job. I don't think I made an active decision, but it was certainly subconscious that I needed to somehow convert my confidence into confidence for the community.
Okay, so I guess that takes me to one of my first questions, which was going to be about the importance of public health education. And you certainly have become, I guess, one of the faces of the public health response to the pandemic. Can you tell us a little bit about that, some of your techniques on how to communicate such complex subject matter and be able to elicit a response from people?
So it has been difficult, and I think the first thing to say is that not every communication style will suit everybody. And so depending on your audience, you have to know your audience, and then you have to tailor messages accordingly. But there's two things that have stood out for me. The first one is the amazing capacity of the Australian public to actually absorb the science, way beyond the usual comms dogma of saying you have to target your written communication to the level of, what is it, a 10 or a 12-year-old or something like that?
Something like that, yeah.
I don't know if that's true.
Okay.
I think that the media has shown a lot of respect in asking us questions. They've given us the opportunity to explain things. Paul Kelly, our acting Chief Medical Officer at the moment, managed to introduce the concept of the basic reproductive number into common discourse. So the number of people who get infected on average from a single person with COVID-19. The R effective number, which is now reported in mainstream media. And so I think people have welcomed some of that technical discussion. And more than that, if you don't provide a level of technical discussion to the public, I've found that people think that you're talking down to them.
Okay, right.
And that's it's certainly some of the feedback that I've had on my own Facebook feeds with the top three. I try not to look at the comments. That's a bad thing. But some of them have been, don't treat us like we're in play school. So you've got to calibrate that. You can't go too technical. And doctors are so good at using jargon.
Yeah.
And the problem with doctors using jargon is we don't even know we're doing it.
Yeah.
We turn around with language that we're so used to. A good example is tests. false positive and false negative tests. Now, that in and of itself requires a little bit of explaining. If you go too far into the science, you start finding words like sensitivity and specificity of a test, which actually requires a good couple of lectures in first year medical school to explain. You can't do that to a public audience, but you can explain what a false not positive and a false negative is with a fair degree of technical detail behind it. And I think understanding that level and that calibration is the key.
Okay, so it's making sure not to overwhelm people, but not talk down to them at the same time. And I imagine that you would need to project a certain amount of, gravitas to say, trust me, I know what I'm talking about, but not an arrogance to say, trust me, and I'm not going to tell you why.
Exactly. And I think, this is something that we need to take into our day-to-day practice. The thing about jargon, whether you're in a government department or whether you're in medicine, is it's a mode of exclusion almost. You form a silo or a club where you can talk in your acronyms and everybody in your club understands your acronym and people outside don't. And that's a sort of means of differentiating yourself from others, not always in the healthiest way. So I think one of the main reasons to move away from jargon, and this absolutely includes, I think, in the public service, is it helps you work as a team. It helps you communicate better. It helps get you all on the same page.
I suppose that forming an exclusive group of people who understand the same language is the exact opposite of what you're going for in public health communication. You're trying to bring people in and make everybody feel like they can make a difference and that they understand what's going on.
That's exactly what we're trying to do, and it's even more acute now after the second wave, when we've got 3 different pandemics in Australia. We've got an elimination phase in Western Australia, South Australia, Northern Territory and Tasmania. We've got a recovery phase from a second wave in Victoria, and we've got what is really a battle to stop a second wave in New South Wales and Queensland. Now, you have to try and sell a message to an Australian community as a federal DCMO, but make people understand that there are differences. So why don't we wear masks as a mandatory measure in New South Wales and Queensland? How do we take that very uncertain science of how masks actually help and the degree to which they help and translate that into public policy? And the way we've done it is to try and explain clearly that there is health evidence, masks work, but then you've got to take the evidence and apply it to public policy, and it comes out of the health sphere. It comes into the sphere of law enforcement. It comes into the sphere of regulation and governance, and that's not our swim lane, but we need to be able to explain that that is perhaps why the New South Wales government is not making masks mandatory. And so I think that that appreciation that there is health, there's scientific evidence, and that needs to be translated into public policy, and that might be the reason for some inconsistencies. That's been the hardest thing to explain, but perhaps the most important from a public communications perspective.
Okay. And I guess on that, with there being different responses across the country, there would also be an aspect where you need to communicate that we're all in this together, like we were with the first wave. There was very much kind of, we're all doing the same things, we're all in this together, we're going to get through it. Now we've kind of splintered off into different responses, as you say. How do you maintain a sense of forward momentum as a whole country doing it together when actually we do have to do different things?
Well, that would be the, several hundreds of billions of dollar economic question, I think. To an extent, we have it a little bit easier than our elected representatives because we can retreat a little bit to the science, to the basic science of viral transmission,
right,
which we can all contribute to and have a sense of agency with. So, like I've said so many times, physical distancing, hand washing, get yourself tested. These are all measures that you can take, and it doesn't matter which phase of that epidemic you're in, whether you're in elimination, recovery, or you're in aggressive suppression. it all makes a difference doing those three things. And so trying to convince the public or continue to energise the public. I think the public were convinced in the first wave, but continue to energise the public, maintain that sense of agency that we can actually all contribute to this. And that means if we keep our hygiene practices as good as they can be, then we'll suppress the virus.
Right, so it's combating that sense of helplessness that can set in, you know, the fatigue of having to go through these motions for months and months on end. Yeah.
The helplessness is a real issue, I think, and perhaps one that it's very difficult for us, and we have to relate to it as public servants. But we've got to keep in mind the very privileged position we hold in the public service with our jobs and our positions and our regular income.
Very secure jobs.
Very secure jobs, in contrast to people in Melbourne at the moment, many of whom, hundreds of thousands, will lose their jobs. There will be those who are in lockdown. I mean, there is nothing that takes away your sense of agency and purpose more than having to sit in your house for weeks on end.
Yeah.
And I think from Canberra, one of the most important things we can do and hopefully convey to people in Melbourne is, firstly, we can sympathise, but we can't empathise because we haven't been locked down for a second time. But that there is that element of understanding that this is different for people in Melbourne and Mitchell Shire, and our policy needs to be different towards them. We need to have increased mental health support. We need to have messages that give them a sense of agency and empowerment. I think probably one of my notable slip-ups was when I suggested that in an effort to get routine into one's day, that making one's bed would be a good thing to do.
Yeah, I did hear that one. Was that a slip-up?
Well, it was a bad example, I think.
Okay. I could see what you were getting at, yeah.
I'm glad a lot of people couldn't, and I think, you know, that again, that's the importance of communication and choosing the right examples. I think you've got to pick, if you're going to use analogy as communication tool, you better pick the right one. You know, that's hard if you're public facing because it can easily be misinterpreted. And I think the make your bed analogy really made people in Melbourne, at least certain people in Melbourne, feel as though we were trivialising their experience.
Right.
And that was the error there.
Yeah. Yeah, I guess that makes sense, and I could see where you were going with it, in that for myself, having worked from home for several months this year and now a few days a week, I still need to maintain that routine. I still get up at the same time, I do everything, I have a shower, I do my teeth, I get dressed, all those kinds of things to be able to maintain that routine, and I assume that's kind of the angle you were going down. You know, don't let your entire life's routine be thrown out. But I can certainly see where people were coming from, thinking, you know, we're not going to fight a pandemic with bed making. So I guess to give you a do-over, what analogy would you use now?
Yes, I think I would stay away from the making the bed, and I would actually give a series of daily activities, maybe 3 or 4, basic still, but you know, to reduce it down to making the bed wasn't the best. Well, it wasn't my best turn of phrase. But I think you're right. The sense of control. If something is taken out of your control, and there is nothing that gives you less sense of control than an unseen enemy like a virus, then you have to do what you can to make your own space controlled and ordered when the rest of the world is chaotic. And I think that can actually be a message to anyone who is suffering psychological distress anywhere in Australia, because one of the things, you know, one of the silver linings is that this has once again shone the light on Australia's mental health. The psychological well-being of Australians is a critical priority for all federal and state health departments, and we need to understand that when we're accessing help, there's a grading of what we can do. We can stick to our rituals, which was the making the bed comment. We can access Medicare-funded clinical psychology sessions, and then, of course, Lifeline Beyond Blue. But just the sense of focus on that, and that it's not just about an individual accessing a service, but it's also about community supporting each other. That's been a really important message. So call your friends and family in Melbourne. If you know someone who's elderly and isolated next door, go and check on them, see if they need groceries or so on and so forth. I think that actually did come out very clearly in the first wave and has come out also down in Victoria in the second wave.
Yeah, that just reminds me I do have some friends down in Melbourne that I need to call, so shout out to you down there.
Exactly.
Yeah. So do you think that there will be a lasting impact on the mental health space in Australia after this, in terms of the maybe stigma in the community may be decreased, the resources may be increased? Do you think there'll be any lasting change?
I hope so. There have been a couple of really interesting initiatives. Dr. Ruth Vine is a colleague, a Deputy Chief Medical Officer, and is a psychiatrist. I think recognising that psychiatry has a natural place in the Chief Medical Officer's group, that's a positive outcome. I do hope the destigmatisation of mental health and psychological distress does occur, and to an extent that is happening with Are You OK Day, and that's really been elevated this year, I think. In the medical space, COVID-19 has created so much anxiety and distress amongst doctors and nurses.
Okay.
And that has an impact. From my own experience working in some pretty challenging conditions in Africa, when you are in a constant state of anxiety, problem is you don't actually realise it at the time because you're so amped, and your body's just firing all these hormones out in that sort of fight or flight mechanism to keep yourself on point and working in challenging environments. But that has a sustained effect in the medium to long term. And I hope that doctors and nurses who are feeling the pressure, particularly those down in Melbourne, do actually seek some sort of professional assistance. And this equally applies in any sort of workplace. There is something to be said about having a general practitioner that's on your side in the mental health space, and who can refer you to good clinical psychologists. And so I hope that those 20 free Medicare visits that the government's offering are being used. It's going to be really interesting to see the MBS billing data on that.
Yeah. If billing data is interesting to you, yeah.
Well, it is now that I'm in the Department of Health.
Yeah. So have you noticed amongst, your colleagues that there is a difficulty in becoming the patient when you're usually the person who's doing the treating?
Yes, there certainly is. It's a big leap at the best of times. Obviously, there have been many doctors and even more nurses. I think it's 70% of the over 3,400 healthcare workers affected in Victoria are nurses, and the remaining are sort of hospital ancillary workers. It's about 20% doctors. But making that transition, it's been well documented by a couple of senior doctors how difficult that is, particularly isolating from family, that concern that you might bring COVID-19 home to the family. So
you mentioned before your work in Africa. I assume you're referring there to your work with Doctors Without Borders? Yes, that's right. Yeah, do you want to tell us a bit about that, what that was like?
Yeah, I'd love to. I was quite young. I think I might have been about 26 or 27, and I'd always had this inkling that I wanted to work with Doctors Without Borders. I'm not exactly sure where it came from, but I sort of applied after my second or third year of residency, and they sent me off to a place called Betu, which was in the Republic of the Congo.
Okay.
So I had no idea where this place was. It was in 2004, and if you close your eyes and stick your finger on a map of Africa, a bit like pin the tail on the donkey, if you get to the middle, that's where Betu is.
Okay.
Right, slap bang in the middle, Central Africa in the Republic of Congo. So the Republic of Congo was the old French Congo, and wasn't the Democratic Republic of Congo, which is where the serious business was going down with conflict but nonetheless, was a post-conflict zone. It was a long way away from anywhere. You had to do a 12-hour canoe ride to get up to this place. It was seriously isolated. And of course, it was back when mobile phones weren't around. So our means of communication was satellite email, which cost us about $15 to send a single email.
Oh, wow. It's not worth it.
And we had, I can't remember, VHF or UHF radio, where we would talk to the guys back in Brazzaville. So it was actually a seriously isolating experience. I was the only person there who spoke English. It was supposed to be a French-speaking mission. So that's an important thing. Don't overestimate your own French abilities when you're going on these jaunts. But I think what it taught me, I think it's always very valuable if one finds oneself in a minority somewhere. If you're not the dominant culture, then you can start to appreciate what it might be like to be an outsider. The difficulties in communication. I mean, for the first 2 months, I think I just said we to everything. I didn't even know.
What did you agree to?
I mean, who knows? There were people were making statements, comments, rhetorical questions, and I'd just say yes. And it's an important lesson in communication because if people don't understand you, then their standard answer is yes.
Yeah.
And that we can take that into our day-to-day communications in the public service. You've got to be very, very clear that someone has understood what your request is, or has actually heard you, not just listened but actually heard. So I think that in that first mission, that was the big lesson for me, that communication piece. Having to really work hard to understand people, and equally work hard to get myself understood. That was probably the big thing that I was able to take away from that 6 months.
Okay, so that sounds like it's really set you up for all of the communication stuff that you've done since then, being able to communicate to people, not only in different languages or, maybe hand gestures, but all different levels, different types of communication. So I imagine that throughout Africa you would have seen a lot of need for public health education. A lot of treatable diseases over there that could be avoided with, proper education and resources. Is there any story in particular that you can think of that really highlights to you, really drove home to you the importance of public health education and knowledge?
Well, there's several, but I suppose the big one was at the end of that first mission to the Republic of Congo. MSF always sort of try and add something else on to the end just to squeeze a little bit more out of you. And they sent me up to Chad because there was a measles outbreak in the capital, N'Djamena. Now, that was an emergency, a little bit like COVID-19 on a small scale. So it was one of those situations that you just threw every bit of resource at it that you possibly could. But what it highlighted to me was that public health is about affecting change on a mass population level. It's something that you can't get from an individual patient interaction, and it's something you can't even get from a lifetime as a practicing acute care clinician in a hospital. But if you do public health, you've got the ability to impact tens of thousands, if not millions of people. So we had to vaccinate, I can't remember how many kids we had to vaccinate. It was something like 40,000 or 50,000 in a couple of weeks or something like that. And so we did this on a mass scale, but then it exemplified the importance of public health principles, communication being one of them. The first 3 days that we were out there, no one turned up because we were using the wrong people to communicate. Right. We hadn't actually found the right community leaders to tell the mums and dads to bring their kids out. And it took us a couple of days to work that out. Fast forward to 2020, and you've got Greater Melbourne with culturally and linguistically diverse groups who don't share the same communication channels as many Australians, and lo and behold, the outbreak pops up in those areas. Yeah. So these principles of public health are universal and can be applied to any sort of health problem, and we continue to need to do so. Unfortunately, we need to learn the same principles every time there's a pandemic. But I think we've learnt a lot from Victoria, and we'll be able to apply that in other parts of Australia.
Okay. So do you have any tips for how to respectfully engage with people who might be sceptical of the science or maybe sceptical of vaccinations, for example? I mean, it's important to stay respectful. Obviously, no one's going to listen to you if you just call them an idiot. So how do you really convince people to act when people's lives are at stake?
Yeah, that's a really hard one. And you don't always know what effect your communication is having. So to an extent, you have to fall back on those principles of respectful communication, not talking down to people. I suppose the question is, which group are you trying to influence here? And if you use the sort of, this isn't quite right with the numbers, but say there's 0.1% of people who are anti-vaxxers, 10% who are vaccine hesitant, and 90% who are getting their kids vaccinated. Let's transpose that to what people think about COVID-19 and maybe their susceptibility to conspiracy theories. So really, the group that you're trying to influence is that 9.9% that could be swayed towards the conspiracy theories or could be pulled back. Right. And so how do you do that? Well, the first thing is you've got to try and you can't actually do this unless you're talking to people directly, I don't think. So it's a bit of a guess, but it would be an educated guess to say people are looking for solutions because their livelihoods are being destroyed by COVID-19. And so they will look to things like hydroxychloroquine, for example, as a means of, again, giving themselves agency, giving themselves hope, giving Australia a possibility that we might not have to lock down. So then what do you do when there are people who are promoting hydroxychloroquine when we don't have any evidence that it works? I think you have to do two things. You have to acknowledge the point from which people are coming, and it's not a scientific point, it's a social set point, and then offer them some sort of hope. So hydroxychloroquine's not dead. It just doesn't work for acute infection. We are still funding it to look at what we call pre-exposure prophylaxis. So you take hydroxychloroquine to prevent you from getting COVID-19. Jury's still out on that. So you give that hope, and then you give the other aspects of hope that are a bit more tangible than hydroxychloroquine. Remdesivir, we've got a good stockpile of that. It works. We've got great intensive care. If you go into an intensive care in Australia for COVID-19, you are highly likely to come out alive. And finally, faith in the public health response. So if you can demonstrate there is something tangible, it is working, then you can drag people away from some of the less evidence-based things like hydroxychloroquine, but that is still an important potential drug. And then, even further down the fringe elements like 5G and that sort of thing, I think that's hard to combat, but if you use those principles of respectful communication, you've at least got half a chance.
Okay, so it's not so much about trying to fight people on every thing that they call a fact, but it's more kind of saying, what are people wanting here? People are wanting hope. How do we give people hope with something that may actually work?
Yeah, I think that's exactly right. I think it's because if you believe in 5G, the DCMO is not going to convince you out of that. But the DCMO might be able to offer you something else that is more powerful than 5G and more believable, and so that's, I don't know the behavioural psychology or behavioural science of this. I haven't studied it, but that's my impression, and that's kind of the style that many of us have adopted in the past 6 months.
Okay. So is there anything else you want to talk about today that we haven't covered yet?
I think I just wanted to reinforce perhaps how much of a privilege it's been to work within the Australian Public Service at this time. I had some previous public service experience in NT Health, and obviously I've been a practicing clinician. But from every experience I've had with every echelon of the APS during this response, I have seen people who are absolutely committed to the health and well-being of Australians and doing their best to make the right decisions under difficult circumstances. I won't be in the APS full-time as of next week, but it's been a great experience, and so from everyone, from the head of PM&C right through the APS, everybody's doing a great job, and I look forward to working with you all in the future.
Well, thanks for that. What's next for you then if you're not sticking around?
Well, you can't keep a clinician away from patients for too long, so I'm going back to Canberra Health Services, and we'll do some sort of part-time administration and part-time clinical work. And I've also got a PhD to finish.
I did see that on the ANU website, yeah.
Which has now got a whole heap more material,
yeah.
So hopefully it'll write itself. But
yeah, you can keep hoping that.
Yeah. Well, that's right. It's going to take a little bit of solid effort, but there's so much fertile ground now about how government policy can be developed, balancing the imperatives of quick decision making with the need for good sustainable policy, and if we can start looking at telehealth, the National Private Hospital Viability Guarantee, some of our decisions around the National Medical Stockpile, all these sort of things need to be critiqued firstly, but also put out there in the wider discourse. I'm sure there's a lot of policy decisions that were made in health that the method that we made them could be applicable across the rest of the public service and be helpful in the future.
Right. Well, thanks so much for chatting with us today, Nick. It's been really fascinating for me to hear your experience of the APS. It sounds like quite a different one to what a lot of us would have had. I'm really encouraged to hear how much of a good experience you've had in the APS.
Well, thanks, Miff, and thanks so much for inviting me to do the podcast. I hope it's useful for all the listeners.
My pleasure. And thanks everyone for listening. Don't forget to check out the latest edition of Connecting Us for more stories from your colleagues working in science across the APS. The link will be in the show notes. Stay safe, everyone.
Today's show was written and presented by Miff Nazette, with editorial input from Lorena Hernandez and Richard Zilkowski. Matt Bully did the sound editing. Original music is by Ed Reading. Special thanks to Dr. Nick Coatsworth for his time and insights. Thanks for listening. We look forward to sharing more APS stories like this one with you through Connecting Us.